Hello, we're going to jump into chapter 31, the musculoskeletal system. And this works as a very nice overview of the musculoskeletal system, some A&P review, and then it jumps into lab work, diagnostic, testing, and then common causes of issues inside the musculoskeletal system and the various treatment modalities and prevention mechanisms that we can use. So I have a really great video I want to play for you that gives a nice clean summary of some key musculoskeletal system. So I will jump back into lecture after we watch this video.
Each time you take a step, 200 muscles work in unison to lift your foot, propel it forward, and set it down. It's just one of the many thousands of tasks performed by the muscular system. This network of over 650 muscles covers the body and is the reason we can blink, smile, run, jump, and stand upright. It's even responsible for the heart's dependable thump. First, what exactly is the muscular system? It's made up of three main muscle types: skeletal muscle, which attaches via tendons to our bones; cardiac muscle, which is only found in the heart; and smooth muscle, which lines the blood vessels and certain organs like the intestine and uterus. All three types are made up of muscle cells, also known as fibers, bundled tightly together. These bundles receive signals from the nervous system that contract the fibers, which in turn generates force and motion. This produces almost all the movements we make. Some of the only parts of the body whose motions aren't governed by the muscular system are sperm cells, the hair-like cilia in our airways, and certain white blood cells. Muscle contraction can be split into three main types. The first two, shortening muscle fibers and lengthening them, generate opposing forces. So the biceps will shorten while the triceps will lengthen or relax, pulling up the arm and making it bend at the elbow. This allows us to, say, pick up a book, or if the muscle relationship is reversed, put it down. This complementary partnership exists throughout the muscular system. The third type of contraction creates a stabilizing force. In these cases, the muscle fibers don't change in length, but instead keep the muscles rigid. This allows us to grip a mug of coffee or lean against a wall. It also maintains our posture by holding us upright. Skeletal muscles form the bulk of the muscular system, make up about 30 to 40% of the body's weight, and generate most of its motion. Some muscles are familiar to us, like the pectorals and the biceps. Others may be less so, like the buccinator, a muscle that attaches your cheek to your teeth, or the body's tiniest skeletal muscle, a 1 millimeter long tissue fragment called the stapedius that's nestled deep inside the ear. Wherever they occur, skeletal muscles are connected to the somatic nervous system, which gives us almost complete control over their movements. This muscle group also contains two types of muscle fibers to refine our motions even further: slow twitch and fast twitch. Fast twitch fibers react instantly when triggered, but quickly use up their energy and tire out. Slow twitch fibers, on the other hand, are endurance cells. They react and use energy slowly so they can work for longer periods. A sprinter will accumulate more fast twitch muscles in her legs through continuous practice, enabling her to quickly, if briefly, pick up the pace. Whereas back muscles contain more slow twitch muscles to maintain your posture all day. Unlike the skeletal muscles, the body's cardiac and smooth muscles are managed by the autonomic nervous system, beyond our direct control. That makes your heart thump roughly 3 billion times over the course of your life, which supplies the body with blood and oxygen. Autonomic control also contracts and relaxes smooth muscle in a rhythmic cycle. That pumps blood through the smooth internal walls of blood vessels, enables the intestine to constrict and push food through the digestive system, and allows the uterus to contract when a person is giving birth. As muscles work, they also use energy and produce an important byproduct: heat. In fact, Muscle provides about 85% of your warmth, which the heart and blood vessels then spread evenly across the body via the blood. Without that, we couldn't maintain the temperature necessary for our survival. The muscular system may be largely invisible to us, but it leaves its mark on almost everything we do, whether it's the blink of an eye or a race to the finish line. This video is made possible by our community on Patreon, and if you're curious about the human body, check out this playlist.
Okay, so lesson 31.1, the musculoskeletal system theory objectives. What are you going to be able to do after listening to this voiceover PowerPoint? Well, you should be able to describe the normal anatomy of the musculoskeletal system. You should be able to show how the musculoskeletal system provides the function of movement, discuss how the musculoskeletal system provides protection for the body, illustrate the causes of disorders of the musculoskeletal system and ways to prevent them, compare the procedure and nursing care for the following diagnostic tests: a bone scan, arthroscopy, electromyography, and distinguish ways in which older adults can increase musculoskeletal strength and protect their bones. Our clinical practice objectives, things that we should be able to pull over into the clinical side of things after listening to this voiceover PowerPoint. We should be able to perform an evaluation of a patient that has a musculoskeletal disorder, assist in the development of a nursing care plan for a patient with a musculoskeletal disorder, use measures to reduce the chance of contracture for patients with musculoskeletal injuries, assist patients with musculoskeletal injuries with active or passive range of motion, and reinforce teaching about how to properly use an assistive device. The structures of the musculoskeletal system. It's made up of a lot of parts and pieces. We have 206 bones in our skeleton. We have compact bones and spongy bones. We have long bones like the femur, short bones that are cube-shaped like our carpals and metatarsals in our hands and our feet. We have flat bones like our skull bones or our sternum, our ribs, our scapula. And we have irregular bones like our spinal bones and our mandible. We also have joints in our body. This is where two bones come together. Joints can either be immovable, like our skull joints, right? Like where our pieces of our skull come together. We don't want those to move. Slightly movable, like our vertebrae, where they're those gliding joints, or freely movable joints, like the hinge joint of our elbow, the pivot joint of the top of our hand, the head of the radius, the saddle joint of the thumb that can move in clockwise and counterclockwise rotation, or the ball and socket joint of the hip, where the head of the femur enters the acetabulum of the pelvis. We also have cartilage. Cartilage are fibers and cells that are pushed into this gel-like substance and work to cushion various parts of our musculoskeletal system. Ligaments that join bones together inside of a joint, tendons that provide for joint movement and are how skeletal muscle attaches to a bone, and then our beautiful muscles, which we saw a lot about in the video, our skeletal, cardiac, and smooth muscles. Other notable structures of the musculoskeletal system include the bursa, which are fluid-filled sacs that cushion joints, like our hip, for example. We do have a hip bursa, and it's just a sac full of fluid to allow that joint to reduce friction and be more movable. And then we have fascia, and that's a connective tissue that surrounds and separates our muscles. You hear that a lot in surgery, that they're going to cut through fascia when they're doing surgery. And so there are some of the major bones of the human skeleton: our skull, our scapula, our humerus, our radius and our ulna in the lower forearm, our carpals, metacarpals, and phalanges in our hands, the long bone of the femur, the patella, the tibia and the fibula in our shin, and the tarsals, metatarsals, and phalanges in our feet. We also have our coccyx and our sacrum, and we have our pelvis. General features of long bone. So we're looking at a long bone here. We have the epiphysis, or the end of the bone on either side. We have articular cartilage, which is where we meet another bone. We have the epiphyseal line, which is where we see a lot of breaks in the elderly, especially in the hips. That spongy bone that has that red bone marrow, which helps to form red blood cells, platelets, white blood cells. Compact bone, which just serves to protect our bone, right? We have the endosteum, the periosteum, which are our layers of bone, and the medullary cavity. Okay, functions of bones, what do they do? Well, they provide shape to our body. The skeleton supports and protects our inside parts. For example, our ribs protect our heart and our lungs. Spongy bone, we talked about, has that nice red bone marrow, which produces red blood cells, white blood cells, and platelets. And our bones, especially in those canals of our bones, there is the crossover of nutrients and waste and minerals. The osteocytes or bone cells of our bones store and release calcium and phosphorus and work with that mineral balance. Vessels transport out nutrients and waste from the canals, and our bones are continually remodeling to allow for growth and healing and just changes in our body as we age. So, continual remodeling, we got osteoblasts that build bone, and we have osteoclasts that cut down or destroy bone. Functions of our muscles. Now, this is contraction, movement, joint stability. They maintain our posture. They produce body heat. And then the shortening of stretching of muscles allows for joint movement. Muscles work together in order to produce movement. So we have a shortening and a stretching. On one side, we have the shortening. On one side, we have the stretching. And that opposing muscle group involvement and collaboration provides movements in the joints. Disorders of our musculoskeletal system. So as we know, things happen. Disease, trauma, malnutrition, and aging can cause issues with our musculoskeletal system. Poor nutrition, weak bones, right? We don't get enough calcium, we don't get enough phosphorus, we don't get enough vitamin D, we're not gonna have nice strong bones. Not eating enough protein and eating our muscles to provide that nutrition to our body. So making sure that we get enough protein. Malignant tumors, especially those that metastasize to bone and take up space and take energy, right? And then estrogen and osteoporosis. We do know that the decrease in estrogen production after menopause in women can be a contributing factor towards the occurrence of osteoporosis. So how do we prevent these issues? Well, we do weight-bearing exercises, which make our bones and muscles strong. We utilize safety measures like wearing a helmet when we ride bikes, wearing a seatbelt when we ride in the car, and such. Not having rugs in the house with our elderly people, covering any kind of extension cords or not using extension cords at all if we can avoid it. And then making sure we're eating lots of good food. So food that's going to give our body the calcium, the phosphorus, the protein that we need to do good work and to grow healthy and strong. And then smoking is linked to issues inside of our musculoskeletal system. So by avoiding smoking, we can actually help our body be stronger and healthier. We also don't want to use steroids on a long-term basis because that can actually cause osteoporosis and break down the bones, which can lead to fracture. So it's important that we take good care of our body. Foods, talking about nutrition for a second, foods that are really good for us are foods high in calcium, like cheeses and yogurts and milk. We can also eat sardines and salmon, tofu, figs, and apricots. We also need magnesium and vitamin K to have nice, healthy bones. So those are your green leafies like spinach and meat, right? Diagnostic tests and procedures for the musculoskeletal system. So we do blood tests, right? So calcium and phosphorus go together. We need them for good bone growth. So we'll check for those. We'll do a total calcium and a phosphate test. We can do that through the blood. And we don't want to see them low, right? If they're low, then we don't have enough to produce nice, healthy bones. However, if we have a very high calcium outside of normal range, that may say that we're not moving the body enough. We've got immobilization and potentially the development of spurs or contractures, or we have cancer that's metastasized to the bone, so overgrowth of the bone. We also wanted to detect bone disorders other ways, like look for bone metastasis with an alkaline phosphatase test or an ALP. If we have an elevation in that level, it can tell us we may have Paget disease or we've got metastasis of our cancer to the bones. So that is not good. We look for creatine phosphokinase levels or CPK levels, which would tell us that we have muscle damage. Uric acid test can tell us if we're at risk for gout or gouty arthritis. And then we also may have an elevated uric acid level when we have things like rheumatoid arthritis or other connective tissue diseases. We also can diagnose rheumatoid arthritis with rheumatoid factor. So that's important. Excuse me, uric acid is for gout and rheumatoid factor is for rheumatoid arthritis. I want to clarify. And then the goniometry is a tool. There's a goniometer. It's a little tool, often plastic, that we can use. It measures angles and it allows us to measure joint motion. So here's a good picture of that goniometer and what actually is going on there. They're measuring the angle of movement and ability of range of motion. Okay. Other diagnostic tests and procedures that we use to evaluate the musculoskeletal system, we've got X-ray, right? Obviously X-ray. X-ray is great for fractures. So we want to look at bones to see if there's any issue with this continuity of the bone, right? Also, if there's like severe joint damage, we may be able to tell that on X-ray as well. Of course, we want to be sure that we ask if the patient is pregnant before we do an X-ray because there is risk of radiation exposure to a developing pregnancy. MRI, we may have an MRI versus an X-ray when we want to look at muscle structures, more connective tissue structures, right? We're going to get some more soft tissue in the MRI. Thing with an MRI, it is magnetic resonance imaging, so we do use magnets. There can't be any metal in the body and no metal implants because of the magnetic field. It would pull it out of the body onto the machine, and that would be catastrophic for the patient with a metal implant or serious metal inside of the body. The patient also has to stay still for 15 to 60 minutes. These take a long time. And because they take a long time, some patients have issues with like claustrophobia or staying still. MRI may also use contrast, so then we worry about our contrast issues, right? But more often we see the CT with contrast. Regardless, whenever we have contrast, we want to assess for allergy to iodine or shellfish. We want to assess for contrast, nephrotoxic medications, because contrast is very hard on the kidneys. So in combination with something like metformin, we may have issues. So we want to assess if they've had metformin or if they are taking it or will take it after contrast. We may do a CT to look at more detail, right? Specifically the spine and the skull. The CT also is the gold standard for soft tissue. So we would be able to see bleeding and things like that on a CT. That patient lays down on the hard table and it only takes about 10 to 15 minutes. They may get that contrast dye and they'll hear those click, 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 clicks as the machine goes around the body part to really get those nice images that we need. The patient has to lay very still for the CT to be successful. And then CT with contrast is the most common contrast using test. And so that's where we definitely need to assess for allergies if they're going to get the contrast media. Orthography, I'm skipping a step. DEXA scans. Okay, so DEXA scan, we use this for density, bone density, right? It can be used to tell us if we have a bone disease, but a bone scan is what we use for tumor, metastatic growth, injuries to the bone, degenerative bone diseases, and DEXA scans are more for density. So think disease with scan and density with DEXA. DEXA is going to show us if you have osteoporosis or osteopenia. Bone scan will tell us if you have cancer in your bones, right? With the DEXA, it is radiation. So obviously our typical radiation precautions. And we want to measure your height in order to put that into our calculation and also get our camera calibrated. We take off all metal objects for this one, and it takes about 30 minutes. The bone scan can take anywhere from 30 to 60 minutes. We want to check for allergies or pregnancy because we're going to give that IV radioisotope for our bone scan, okay? And it's going to measure how long it takes for that substance to be taken up by the bone, and then we're going to see where it goes on the imaging. All metal must be removed for that one as well. And the patient will not be radioactive. However, their secretions can be. So like double flushing the toilet, double gloving when we take care of their emesis or their stool or their urine. It takes about 6 to 24 hours for that radioisotope to clear the body. Okay, arthrography or an arthrogram. We get good pictures of joints with this one, right? We're able to see those really nice soft tissue structures that we weren't able to see on x-ray potentially. We may even pull some fluid out of the joint space, do a joint aspiration. They may get a contrast agent injected into the joint so that they can see it very well. And then they'll manipulate that joint to get that contrast agent all moved around and then take some x-rays while they're in various positions. They need informed consent for this procedure. And sometimes it can be painful. So we want to make sure that they get some medicine for that. We want to watch for swelling because as we manipulate the joint, that can cause issues. And then crackling sounds can be is normal after this. We do hear them or feel them in the joint, but they go away after 1 to 2 days. And that's usually from the injection of the air or contrast agent or whatever we put into that joint, okay? Arthroscopy is when we're going to put a camera in there. So they're going to get some local, we'll do a little incision and we put that camera down in there and look inside of the joint. And during an arthroscopy, we often do a lot of cleaning out, right? Arthroscopy and some debridement inside of the joint. So we're able to actually pass some instruments through in order to either biopsy or clean out the joint. Sedation is often given, monitored anesthesia or a MAC is your most common type of anesthesia. So that's typically propofol. These patients need to get up and move around afterwards, but we don't want them to overuse their joint. So unusual bleeding or swelling would be concerning, but we want to put ice on there to prevent that, right? So that's super important. Arthrocentesis, we're going to be extracting fluid from the joint, so synovial fluid, to look at it and see what's going on. Especially if there's a lot of swelling there, it actually can cause a reduction in pain as well if we aspirate some of that. So this may be under ultrasound or fluoro. We may end up doing an injection of steroid to provide them some relief afterwards. And then we would want to immobilize and ice that joint afterwards. So this is the one where we really don't want them to overuse that joint because it could cause serious issues. And then biopsy, I mean, that one's pretty straightforward. We biopsy bone to see if we've got a tumor. We biopsy muscle to see if we've got some kind of overgrowth of tissue, right? Or some abnormal replication of tissue, which would be indicative of cancer. So that can be painful sometimes. Ice if we need it, right? Watching for bleeding, circulation, etc. Making sure everything's good to go on that. EMG is electromyelography. And what we're doing is we're detecting how well the nerves and the muscles are talking. And if the nerves are doing their job, which we're going to actually work as synthetic nerves and stimulate muscle, then the muscle should be doing its job. It's going to help us figure out if we've got a dysfunction of the muscle and how we can fix that, right? It'll help us come up with a better idea for how to fix that. This is a needle electrode procedure, so it can be a little bit painful. We do need a signed consent for this procedure, and we don't want to give them any medications that can mess up the results. It takes about an hour. We want them to not take any muscle relaxants, anticholinergics, or cholinergic drugs before the test. And then we don't want them to have any caffeine or smoke 3 hours before the test because it can cause a false reading. Physical assessment. So when we're looking at patients and doing our musculoskeletal evaluation, we're going to look at their posture. We're going to see how they sit or how they stand. Are they hunched? Are they not able to maintain a posture that's equal on both sides? How do they walk? Do they have an awkward gait? Do they have difficulty getting up or walking around? Are they wincing while they move? Look for all of those things. We want to see if they're able to move the various parts of their body without problems, like their knees and their hips and their arms, and lift their arms and pull them back down. What is their range of motion like? As they lift their leg, are we hearing or feeling crepitus, right? That cracking sound of grating bone on bone. That's not normal. We don't like that. Strength, are they nice and strong, equal bilaterally? How does their spine look? Is there an issue with its appearance as far as it's shifted to the left or to the right? They may have a scoliosis of some type. Do they have kyphosis, or the bending and a humping in the back of their shoulders? How do their joints look? Are they swollen? Are they red? Are they warm? How does their skeletal muscle look? Do they have any bruising? Can they perform their ADLs, or activities of daily living? While they're performing those ADLs, are they having any changes of facial expression that would indicate that there is pain or discomfort trying to get something accomplished? And then with our older adults, do we have an issue providing care? Like, are they able to provide their own care to themselves? Are they able to walk around without falling down, right? Do they need some kind of assistance in order to do everything that they need to on a daily basis? Care planning for these patients. So a big thing, especially if a patient has fallen, let's say they've broken their hip and they're confined to the bed, we have to get them to the toilet, right? Especially if at home they are completely continent. We don't want to leave these patients in a bed, using the restroom on themselves when they're able to do it themselves and they just need some assistance. Planning for toileting regularly is super important for these patients. If you don't do that, you can cause them to become incontinent all of the time, right? Or you may cause skin breakdown, or they may become very stiff because you're not moving them enough. Speaking of moving, are we repositioning them every 2 hours, right? Left to right, up and down, all of those things. Physical therapy, are they doing their range of motion exercises? Range of motion exercises are critical. They're critical for prevention of issues, and they're critical for recovery from issues. Physical therapy is huge. Lifting and turning your patient. So when you're working to turn your patient, you need to be gentle, of course. You need to explain everything to the patient, why we're doing this, how we're going to move you, talk through the movements, and then be firm. Yeah, you don't want to be gentle but firm seems counter like they're working against each other, right? But we want to be gentle in our movements, but quick and direct about it, right? That way we're not prolonging the situation. Making sure that if you have a patient that requires two people to turn them, that you ask for help, right? It's best done with two people all of the time if we're boasting or something like that. So getting the help that you need, and the training if they need a special kind of device like a Hoyer or a sit to stand, something like that. The patient is able to bend their knees and push with their feet if they can, or hold on to their bed rails and pull up if they can. If they can't help, let them. And then just make sure that you're communicating not just with that patient, but also with the person that's helping you, counting to three. Okay, we're going to move on 1, 2, 3, and going together. That way, nobody gets hurt in the lifting or turning of the patient. Interventions to prevent disability. So, how do we keep from causing continued or worsening breakdown of your patient? We need to work on getting them moving, gradual mobilization, making sure that we're continually looking at how they are able to move their body, how they're able to help turn in bed or transfer, right? How they're able to walk, and getting them closer and closer to being independent again. And as we're measuring their ability to move, we can increase their mobilization or their ambulation goals, right? Just realize that it's up to you to determine their fall risk and to put the important fall risk prevention uh, uh, interventions in place, right? Okay. Exercise program, right? We got to get these people doing range of motion exercises, passive ones, active ones, as soon as we can, right? As soon as we can after we've had a diagnosis of a disease or we've hurt ourselves or we've had some kind of surgery. That helps to maintain that connective tissue, right? And it helps the joint maintain its function. You need to do range of motion exercises with the patient 3 to 4 times a day. Now, things like isometric exercises, which are where you're actually pushing against, like for example, one hand pushing into the other, these are tension exercises. We want to be careful with those. They are very helpful, but in patients that have high blood pressure or increased intracranial pressure, or they have heart failure, it may cause a rise in their blood pressure or their heart rate and cause issues. So just be aware that that could be a, um, uh, I lost that word. Oh my goodness. That could be a contraindication, right? Yes, contraindication. Proper positioning your patients well and comfortably, preventing contractures, right? We know that contracture can set in very, very, very quickly. You can have a person start to develop contractures within 3 days of being immobile. That's a big deal. So we need to be doing the range of motion exercises to prevent that. And we also need to be looking at their ability to move on their own. If they start to develop issues, alerting a healthcare provider as soon as possible. Preventing loss of muscle tone with strength building exercises, teaching them about their assisted devices and helping them use them. And then lots of psychosocial care and support and encouragement, right? That's big. We've got to be encouraging of our patients, especially if they're in the bed for a long period of time. They may be frustrated or feel hopeless or really sad, especially if they're young and they're doing like rehab at a facility. They may become really bitter and angry or feel like they're letting their family down if they had a job that provided for their family before something happened. So, lots and lots of psychosocial support and encouragement. Okay. This is your continuous passive motion machine. This is great for a patient that's had maybe a knee surgery on the opposite side, so we don't want to do it on the leg that's affected, or they've had some other kind of musculoskeletal surgery. We want to provide continual motion without the patient actually having to exercise for the entire period of time. So that is a really nice option for certain patients with order. Sometimes even with we do a total knee, they want this to be done um, education on this to be done beforehand so that afterwards they're able to do that on the affected side within a certain set of parameters, right? Okay. Wrist splints, these are important for helping to increase stability, prevent additional trauma. We need to be checking for swelling, and we also need to be assessing for capillary refill or circulation. We need to be checking our pulses to make sure that we have blood flow to the extremities, and for skin breakdown beneath the wrist splints when we do our skin assessment. Evaluation of our care planning, determine the effectiveness, right? Are we making progress? Are we doing a great job at getting this patient back to baseline? Watch their body language. Is their body language telling you that they're uncomfortable? Are they grimacing? Are they wincing, right? See if they're able to produce ADL progress. Are they getting better and better at holding their toothbrush or holding their fork or putting on their shoes? Look at their studies and labs to see if those are improving, and make sure that we're collaborating, especially with PT and OT and speech, right? Very, very important to promoting their overall well-being and resumption of normal activity. And that's it for chapter 31. I will be back on with chapter 32.